Welcome to Mindfulness for Cancer Survivors Living with Chronic Neuropathic Pain. We're glad you're here. My name is Angie Hunt, Project Manager with Canadian Institute for the Relief of Pain and Disability, and I'll be moderating the webinar today. The webinar is made possible through the support of the Community Gaming Grant Program through the BC Government, as well as donations and memberships to CIRPD. We thank our program partners, Pain BC, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow the presentation with a Q&A based on the questions submitted. Following the webinar, any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You'll be emailed direct links for all these items when they are available. As I mentioned, my name is Angie, and I'll be monitoring the webinar and Q&A session. Our presenter today is Dr. Patricia Poulin. Patricia Poulin is a clinical health and rehabilitation psychologist and associate scientist at the Ottawa Hospital Pain Clinic. She is also one of the key principal applicants on the National Chronic Pain Network, recently funded by the Canadian Institutes of Health Research. Her research focuses on the development and evaluation of various interventions to improve the quality of life of people living with persistent or recurrent pain, including cancer or cancer treatment-related pain. And now I'll hand it over to Patricia.
Thank you, Angie. And I want to also extend my sincere thanks to the Canadian Institutes for the Relief of Pain and Disability for inviting me today. Another part of my personal introduction that I typically like to share myself is that in addition to being a psychologist at the Ottawa Hospital Pain Clinic and an associate scientist at the Ottawa Hospital Research Institute, I also have personal experience of chronic pain, and I have a very close family member who's been living with pain for more than 40 years. And cancer also runs into my extended family, and so I have a lot of exposure and personal experience with cancer itself. And that really fuels kind of my motivation to do the work that I'm doing every day. I'm really kind of passionate to try to improve the care of people who live with pain and to also improve our health system so that it gets more efficient and people don't have to wait as long to access evidence-based treatment. So another part of the practice is that I'm not used actually to present without seeing the audience. I do presentations the Canadian Breast Cancer Foundation, the Canadian Cancer Society, the Canadian Diabetes Association, as well as the Canadian Institutes for Health Research. I also benefit from internal funding here at the Ottawa Hospital. And without this, none of the work that I'll be able to discuss with you would have been possible. So the plan for today is I'll be discussing the problem first of chronic neuropathic pain among cancer survivors, and then I'll examine the role of mindfulness in the management of chronic pain, including neuropathic pain, and I'll discuss the result of a study that we recently completed at the Ottawa Hospital that was run by Dr. Howard Nathan. We call it the AWARE study, and it was focusing on patients with painful peripheral diabetic neuropathy and looking at whether mindfulness might be a useful intervention for them. I'll also present preliminary data from a randomized controlled trial of mindfulness-based reduction among breast cancer survivors living with chronic neuropathic pain, and then I'll discuss implications and future directions arising from this work. I mean, you all know about pain quite well. I will not spend any time discussing pain definitions or chronic pain definition, but I will just draw our attention to the fact that chronic neuropathic pain is caused by lesions to the nervous system or dysfunction within the nervous system itself, and that some of the symptoms that patients often report that are characteristics of a more neuropathic form of pain are symptoms like burning, tingling, numbness, electric shocks, feeling like you're stepping on pins and needles are some of the symptoms that patients report when they have neuropathic pain. Among cancer survivors, there's about 30 to 60% of cancer survivors are affected by pain, and a lot of them it is of neuropathic origin or etiology. And the pain may be due to surgery. It can be persistent post-surgical pain, like in chronic post-thoracotomy pain. There can be phantom pain if the person had to have a limb amputated, or even phantom breast pain for people who have lost a breast to surgery. Neuropathic pain can also result from radiation therapy, such as brachial plexus neuropathy. Neuropathic pain can also result from chemotherapy, and there's some chemotherapeutic agents that are more likely than others to cause chemotherapy-induced peripheral neuropathy, and not infrequently, up to 30% roughly of people can actually develop chronic chemotherapy-induced peripheral neuropathy. And of course, the malignancy itself, the cancer itself, can also cause neuropathic pain. The medical management of neuropathic pain is often challenging. Neuropathic pain is often resistant to commonly prescribed analgesics. Even with optimal medical management, pharmacological management, some degree of pain will often persist. If interventions are effective, or an interventional approach is effective, it may not be sustainable in the long term, and it's dependent on having access to that particular specialist who can do that intervention. And side effects for recommended treatment are not uncommon. So that leaves often people, cancer survivors, with a certain degree of burden of pain that they still have to learn to manage, to cope with, to work with in their day-to-day lives. And in some cases, that pain can be quite disabling. So what can we do? Well, in psychology, and not just in psychology, in pain itself, the area of pain itself, we understand that pain now it's a complex phenomenon. It's a phenomenon that's affected by many factors, and the cognitive behavioral conceptual model is helpful to kind of tease apart these different factors that can contribute to a person's pain experience, and also pain-related disability. So we have the thoughts or beliefs, the understanding or expectations that a person has about their pain and about their treatment. There's the emotions, the emotional states that the person may have that could be due to cancer itself, to the disability that they're experiencing, to the pain itself. And these emotional reactions can also have an impact on pain itself. There's the behavior, the actions, how we do things, what we do. So if we have a tendency to embark in this push and crash cycle where someday pain is better and we really push, and then that sometimes can lead to a few days of being quite flat on our backs and being in a crash cycle. There's also physical factors, of course, like the level of physical tension we carry, our diet, our posture, how we breathe. All of these factors can also have an impact, along with fitness level and energy level. Mindfulness fits into that framework, and it actually fits with a number of elements. And I actually forgot, if I go back just for one moment, that our environment is also really important. And I will not get into the environment right now, but because we'll really focus more on mindfulness and what we can learn and potentially benefit, how we can potentially benefit from this approach. So mindfulness fits within that cognitive behavioral framework. It's defined as the ability to maintain a non-judgmental awareness of our moment-to-moment experiences. Kabat-Zinn is really the person who brought mindfulness really to the forefront in behavioral health medicine and in medicine more generally through his work. And the first study that was published on mindfulness-based stress reduction, which I will describe in more detail in a moment, was published by Dr. Kabat-Zinn, and was with 51 people who had chronic pain and for whom medicine had reached its limits. So there's now, since that initial definition was proposed by Kabat-Zinn, there's been a few more definitions and operational definitions in research terms, how do we measure this that have been proposed. And I will be discussing that a little bit later as well, when I will discuss some of the results of our studies. But in practice, in theory, practicing mindfulness is designed to help us better understand ourselves, to foster some more acceptance of ourselves and our experience. And we know that there is a relationship between pain acceptance and the experience of pain itself and disability. And we now know, thanks to about 30 to 40 years, now 4 decades of mindfulness research, that mindfulness practice has an impact on our physiology, on our emotions, and our thoughts. The most well-studied mindfulness-based intervention is mindfulness-based stress reduction. I'm sure that some of you already know quite a bit about this intervention. There is now quite a wide body of literature about it, not just in the area of chronic pain, but many other conditions, including cancer. But I will summarize it for those of you who may not be aware of what the program entails. So the typical program is 8-week in duration, where people meet typically 2 to 2.5 hours a week, and includes also one full day retreat where that time is typically spent in silence. In addition to that, participants are encouraged to practice between 30 to 45 minutes per day. They're typically given a CD or a link to audio files that they can download and listen on their phone or any recording device, any listening device that will go through the different exercises that are being taught week to week. In addition to the practice itself that I described there, that I list there, that include the body scans, some mindful movement, some sitting meditation with bringing our attention to different foci, such as the breath or sensations in the body, or thoughts even, or sounds in the environment. There's also walking meditation. We practice mindful eating. We also have a practice of practicing loving kindness towards ourselves and others in our environment. And then there is a focus also on trying to really integrate mindfulness in everyday activities, such as choosing just 1 or 2 activities that are routinely done for people day-to-day lives, that might be taking a mindful shower or brushing your teeth mindfully or washing the dishes mindfully, just trying to keep the attention on the task at hand, and when the mind wanders, bring it back. For people who work in a healthcare system, it might be hand washing or responding to a page or a phone call. And in addition to all of these practice, the course also gets into what the foundations of mindfulness are. What are the kind of attitude we want to develop or foster within ourselves that can help us have more equanimity and respond in a more balanced and more adaptive way to the challenge that are presenting themselves day to day. So I will not spend very much time to review the entire literature on mindfulness and chronic pain. There's a couple of good meta-analyses that have been published, and one by Hoff, for example, who's reviewed all mindfulness and acceptance-based studies and found moderate effect sizes for pain intensity, depression, anxiety, physical well-being, and quality of life across those studies. In the chronic pain literature, we see that there has been studies done on fibromyalgia, on arthritis. There's now a study on CRPS starting to come out, but up until very recently, there's actually not been a study on mindfulness for cancer-related pain. the literature on, or this research on mindfulness in oncology really started in the early 2000s by the work of Michael Sveka and Linda Carlson in Calgary. So this work is rooted in Canada, and now there's been several published meta-analyses demonstrating generally small effect for physical health, but moderate effects for mental health following participation in mindfulness-based risk reduction or mindfulness-based cancer recovery. And I will just take one moment here because I've just received a message from Angie to see if there's any problem. No, it does not look. It looks like a false alarm. Okay, so I will continue with my presentation. So, and there's also now some evidence of biological changes from mindfulness practice that's coming out not only in oncology but in other areas. But there's really limited study in chronic neuropathic pain and in cancer-related pain. So one question we might ask is, could mindfulness-based risk reduction be an effective intervention for chronic neuropathic pain among cancer survivors? And this is a question that my supervisor, Dr. Keith Wilson, and I had. And at the time when I did my postdoctoral fellowship here at the Ottawa Hospital Research Institute, my supervisor had a CATALYST grant from CIHR to study pain among cancer survivors. And we were able to do a cross-sectional study to look at different factors that could impact pain experiences among cancer survivors. So, so as I mentioned, we were able to do a cross-sectional survey of 78 cancer survivors. They were all at least 1 year post-treatment and living with chronic neuropathic pain. We found that there was, not surprisingly, and as we had hypothesized, strong correlations between pain intensity, neuropathic pain symptoms, pain catastrophizing, which is really defined as the amount of fear, the amount that we may have of the pain experience itself, as well as the amount of time or how encompassing the pain can become in our lives, as well as how little control or how much control we have towards our pain, as well as disability. And there was a strong negative correlations between mindfulness and all of the above mentioned variables. So we examined then whether or not mindfulness could have an effect, could change the relationship between some of these variables. And in fact, we did find that mindfulness moderated the relationship between pain intensity and the cognitive reactions or pain catastrophizing that people reported. So at low levels of pain, really being mindful didn't change anything. But at high levels of pain, when people were rating their pain, at 6, 7, 8, 9 out of 10, they had less of a tendency to engage in this maladaptive thought pattern that is very understandable. I think anybody who experiences pain may experience fear, of that pain until they understand sometimes that pain can be a disease in and of itself and may not mean that the system is being harmed further, for example. So we found that mindfulness did have that effect. And we also found a really encouraging trend towards mindfulness moderating the relationship between pain and disability. Again, at low level of pain intensity, being mindful didn't seem to make any difference. There was a kind of a floor effect there. But at high levels of pain intensity, being more mindful meant that even in the presence of pain, the person felt that they would still be able to take part in their day-to-day activities and to be not as affected by pain itself. So, and then what also encouraged us was that there was close to 2/3 of participants interested in participating in a study examining non-pharmacological intervention if we could offer one. And that was very encouraging for us to pursue this line of inquiry. In parallel, our team here at the Ottawa Hospital led by Dr. Nathan, at the time, Dr. Howard Nathan, who's an anesthesiologist, a pain medicine specialist. So he was able to obtain funding from the Canadian Diabetes Association to examine the effect of an interdisciplinary program that included mindfulness-based stress reduction on a host of variables, including psychosocial function, pain perception, disability, and quality of life among patients with painful peripheral diabetic neuropathy. And this was really building on the evidence that we were starting to gather of that relationship between mindfulness and more positive outcomes in patients with neuropathic pain, a study that we had done in diabetes as well, and on the fact that although there was a lot of good evidence from supporting the use of mindfulness in general chronic pain population, there was not a lot of work done in examining mindfulness for neuropathic pain. So this was a randomized controlled trial that compared medical management augmented by a mindfulness-based stress reduction program to medical management and a waiting period. The participants were adults with diabetes who had to have good glycemic control at the time of entry into the study, because we know that glycemic control in diabetes could impact neuropathic pain and the progression actually of neuropathy in that group. And they had to have painful peripheral diabetic neuropathy for more than 6 months. And our primary hypothesis was that there would be at least 30% more responders in the group that received the mindfulness-based intervention in comparison to the control group that only received the medical management. And we defined the responder based on literature. So we used the brief pain inventory interference scale. It's a scale with 7 items. It looks at the degree to which pain interferes with different aspects of a person's life. And we know from the literature that a 1-point improvement is actually a clinically meaningful improvement. It's minimum clinically clinically meaningful change. So, after participants got enrolled into the study, they were assessed by a nurse specialist and a pain specialist. There was a review of medication that was done. Then the patients were offered different options for pharmacological management, if that was appropriate. If some agents like pregabalin or gabapentin had never been tried before, then that would be introduced in a conversation. And if the patient wanted to pursue pharmacological management, then they had an option to do so right then and there. And then once they were on a stable regimen for a minimum of 2 weeks, they could then be randomized to the group mindfulness-based intervention. So for that group, this is our consort diagram. So we assessed actually 255 people. There were a lot of people excluded for various reasons, but we were eventually able to randomize 66 people who agreed to take part in the study. There were 33 allocated to the intervention and 33 allocated to the wait list. We only had one withdrawal we actually only had 2 withdrawals from the mindfulness-based intervention and 1 withdrawal from the control group, which is actually quite a good retention rate for our study. And if we just scroll down right to the bottom there for the analysis, we actually had 30 analyzable cases in our intervention group and 32 in our control group. If we just take a look at who in the end participated in the study, participants were on average about 60 years of age. We had about an equal distribution of men and women. Most people had at least moderate levels of pain, and we had about a third, a bit less than a third of participants who were reporting severe pain. So that's 7 or above on the visual analog scale. And participants had on average moderate levels of low moderate levels of pain interference, and had been actually experiencing pain for quite a long time, 7.4 years on average. And this is the result for The brief pain interference. We saw clearly significant improvements in the mindfulness-based reseduction group, while the control group remained fairly stable in terms of the amount of disability, pain-related disability that they were experiencing. And we saw that change from pre-intervention, which is that visit 2, to post-intervention, which is visit 3. And actually that continued to improve at 3-month follow-up, which is visit 4, which is really interesting and tells us how robust the effect was of the intervention in this group. And if participants, we can explain that participants are really encouraged to continue practicing after the program, and this may be one of the reasons why we see this continued improvement, although we did not examine more closely the mechanisms of change and why we saw that an improvement continue. Although the mindfulness-based stress reduction program is really, the goal of participation is really not to reduce pain itself. We don't make the assumption or the promise that meditating will reduce pain itself, but it's not uncommon for people to experience some relief from their pain and to or to feel like it's less, that it is less intense. And we saw that actually in the group, and there was a statistically significant improvement, and that's actually also clinically meaningful improvement from pre to post mindfulness-based intervention, and continued at follow-up at visit 4, which is 3 months after the end of the MBSR class. We also examined whether or not participation in the group would change the degree to which people had some negative thoughts about their pain. So the PCS is the pain catastrophizing scale. So looking at the amount of fear that the person has towards their pain, the amount of threat that the pain produces, as well as how much control or lack thereof the person feels, as well as really how much time they're really focused on their pain day to day. And we found that indeed there was also improvement through participation into MBSR compared to control. Now, interestingly enough, another question we had was, okay, so we see that pain catastrophizing decreases. Is this the mechanism through which the intervention has an effect? And we were interested to see whether or not mindfulness in and of itself, through a measure that we, the 5-facet mindfulness questionnaire, whether or not that could explain the mechanisms through which the intervention had an effect. So a student of mine, Amanda Carson, who actually just defended her thesis last week at York University, did carry out the mediation analysis using the data that we had from the AWARE study, and demonstrated that there was a direct effect of group of the intervention. And there was, I apologize about this, when I'm moving my cursor, it's sliding to the next slide. So there was also an effect of the intervention on pain catastrophizing, but when we actually put pain catastrophizing and mindfulness head-to-head in a mediation model, mindfulness was a mediator of the intervention effect, a partial mediator of the intervention effect, and pain catastrophizing was surprisingly not. But if we could take a look back at mindfulness theory, it actually makes sense, because mindfulness does not, mindfulness practice does not seek to really challenge the content of thought, but to change the relationship we have to those thoughts. So yes, we saw a diminution in pain catastrophizing, but it is perhaps more through the change in the relationship that we have towards that tendency to catastrophize that that potentially the intervention may have an effect. We did not have the power to conduct more sophisticated analysis using techniques like structural equation modeling, but I anticipate that we will soon, as we will have a number of studies on mindfulness and neuropathic pain that will provide us sufficient power to take a look at these mechanisms more closely. So this actually gives us quite a bit of hope around our cancer population and looking to see whether or not we could use mindfulness-based risk reduction to try to improve quality of life and reduce disability among cancer survivors. And we were fortunate to be able to secure funding, to obtain funding from the Canadian Breast Cancer Foundation, as well as the Canadian Institutes for Health Research, to carry out this study examining the effect of an interdisciplinary program, again, that included mindfulness-based risk reduction on a number of outcomes, but primarily pain interference as our primary outcome. So this is a randomized controlled trial with 108 women or breast cancer survivor that compares medical management alone to medical management plus the mindfulness-based risk reduction program. We're enrolling, we actually have enrolled because we finished recruitment, women, adult women with a working knowledge of French or English, who had a previous treatment for breast cancer, but who were at least a minimum 1 year post-active treatment. And that's because we know that some pain condition that develop through cancer or as a result of cancer treatment sometimes can remit just by healing, by time and healing. Although the time pattern is not clear-cut, but some people actually start having pain later on related to their cancer or cancer treatment. But we wanted them to not to have the compounding effect of the treatment itself or the natural recovery that could occur after treatment. They had to have at least 4 out of 10 on the pain intensity rating, and because we could suggest some change in medication, we asked that women who were pregnant or breastfeeding not enrolled in the trial itself, but we typically offer just entry into one of our mindfulness-based course if they were interested in exploring that option. And our primary hypothesis, much like the AWARE study, was that there would be 30% more responders at 3-month follow-up. So I don't have all the results yet. And in fact, before I get to the preliminary results, I will expand a little bit more on the trial and share with you some of the scales that we're using. In terms of self-report scales, along with pain intensity, we're examining neuropathic pain symptom, we're looking at depression, profile of mood states and perceived stress, as well as quality of life. And we have a number of sub-studies that are actually optional for our participants because we're sensitive to participant burden, but I must say that we've had actually quite good uptake. We have a study looking at the cognitive effects of MBSR, and that's a collaboration with Dr. Barbara Collins here at the Ottawa Hospital Research Institute, she's a neuropsychologist. We have a study looking at whether or not participation in the mindfulness intervention leads to change in biomarkers of stress and immune function. And that's a collaboration with Dr. Lori Ma, who's one of our research associates. And we have also a sub-study looking at change in brain structure and activity during specific tasks that we examine with fMRI. And that's a collaboration with a neuroscientist at the University of Ottawa, Dr. Andrea Smith. So in terms of the assessment time points, that's pretty straightforward. People fill out the questionnaires and provide us with their samples when they have enrolled into that sub-study, before medical treatment, after MBSR, and at 3-month follow-up. We have reduced the burden on participant for cognitive testing, where we just do it after medical treatment and after MBSR and at 3 months, and for the fMRI, just pre-MBSR and post-MBSR, so after medical treatment and after the intervention. So I'm going to be presenting preliminary results because we have not finished doing our analysis here. Really, the only study that is completed now is the functional neuroimaging study. So with 30 participants, we had an average age of 50 years old, 52 years old, so a little bit younger than our the participants in the AWARE study. Mostly Caucasian. Still, we had a lot more people in this study who were employed full-time. Most of them were actually quite well educated with post-secondary education, and they had average pain interference and average pain intensity that they reported. So 4.5 and 4.7 on average on a scale of 1 to 10. And if we look at those preliminary results, so this is the brief pain inventory interference scale, and we see that there is an improvement in the treatment group compared to the control. And if we look at pain intensity, we see also the same pattern. So this is very encouraging results for the fMRI study, and I thank all the participants who agreed to take part in it, because I know for many this is a difficult task to do, just to go through imaging and then to do some of the activities that we asked them to do while being in that contraption. So the neuroimaging study consisted in a 1-hour scanning session with a high resolution structural scan. We did functional neuroimaging during an emotional Stroop task where we presented to participants a number of words, and some of those words were pain-related words, or words that had more of an aversive quality, and then some of those words were just neutral words, and then we see which areas of the brain get activated when these words are presented and when we're asking them to do some simple task on a keyboard. And then we also have a functional neuroimaging of them just resting, and we're using techniques like diffusion tensor imaging to look at white matter integrity. I don't have all of the results to present today from this study, but I will share some results of the scan for the emotional Stroop task. So we indeed did find, this was what 10 participants in each group, so 10 participants in the MBSR group and 10 participants in the control group, that during exposure to the words that had aversive quality or pain, the pain-related words, we saw there was less activation in the primary and secondary somatosensory cortices after the intervention in the MBSR group. We also saw some less activity in the coded tail, where we have motor processes, we have learning, we have inhibitory control, as well as the coded tail is also part of the reward system. And we also had less activity in the right mid-anterior insula, where there's a lot of emotional processing, perception, self-awareness as well, that this region of the brain is being associated with. So all of this is also quite encouraging, and I think very helpful in terms of communicating with people what might happen when we're practicing mindfulness. So the preliminary evidence that we have in some is that, it's too early yet to say definitely that MBSR is effective in reducing disability and improving quality of life among cancer survivors living with chronic neuropathic pain. I have yet to do all of my analysis. And also this is only with a group of breast cancer survivors who were 1 year post-treatment. So there's a lot of work to see whether or not timing of intervention, just for example, might also be an aspect to consider. We certainly saw from the fMRI study that MBSR had a significant effect on brain activity during a cognitive task that engage emotional, intentional interference processes. and that MBSR reduced activity in brain regions of the pain matrix that are involved in rumination, sensation, body representation, inhibitory control, self-regulation, and emotion. And this points towards, giving us some encouraging news that that this non-pharmacological intervention can really improve the lives of women in particular, but potentially of all cancer survivors who are living with chronic neuropathic pain. Some questions that remain to be answered that I'm very curious about is to see, are there specific mindfulness practices that are particularly useful or not useful for cancer survivors living with chronic neuropathic pain, and may those vary depending on the timing of the intervention. MBSR, the Mindfulness-Based Risk Reduction Program, and a number of the second generation MBSR program or MBSR type programs that have their own adaptation encompass a number of different mindfulness practices. The body scan, the mindfulness focusing on the breath, or being aware of sounds or sight in our environment. Those are very different ways of directing our attention, and may they have different benefits or different use or application. That's something I think that needs to be studied more. Are there people who benefit more from mindfulness-based intervention than others? And for those who don't benefit, might a CBT or cognitive behavioral therapy-based intervention be better, suited for them? And our team now is just finalizing a meta-analysis of CBT versus MBSR intervention to really kind of look at them head to head. There's not enough really evidence and data that can help us guide people towards one intervention or the other at this time. And then another really critical question is, how can we increase accessibility to these interventions? I mean, the typical MBSR program is done face-to-face in a group. I know in our region here, we cover a very large catchment area. Our cancer center covers a large catchment area, and we have people who travel here, 2 hours for their appointments. Well, how reasonable is it to ask them to travel 2 hours back and forth to attend a 2-hour course if that course is not available in that community, if there's not the critical mass to offer it there? So accessibility is also really important, and there is now some burgeoning evidence that conducting the intervention online, face-to-face, is not as effective, but is effective, better than nothing. And we are currently studying that in a group of cancer survivors where we've expanded really our inclusion criteria to include people who are still ongoing active treatment and who have any cancer diagnosis. And we just deliver the intervention online while they're in their home. We have found that people are actually quite enthused about having that opportunity, but we don't have the results of that study yet to say how effective it was. And I think to push the boundary even further, I think we really need to start looking at asynchronous interventions. So interventions where if somebody is not feeling well one day, especially in the cancer population, if they've just had their treatment and their energy level is quite low, they can't even maybe sign on to listen or participate in a online group intervention, then how can we offer that intervention in such a way that people can access it at any time and have access to the material, as well as being able to access therapeutic support to implement the practice and see how that might work. So our team now has a structured video-based program that is meant to be pilot tested now with people with chronic pain to see how helpful is this, and how much therapeutic support do people really need in order to be able to start engaging with the practice in a way that's beneficial and examining what the impact is. So I guess in conclusion, there's a lot more work to be done, but I think we're all moved by similar goals of improving the lives of people affected by chronic pain, improving especially the lives of people who are affected by chronic pain due to their cancer or cancer treatment. We know there's this famous statistics, I think, that, despite costing more than cancer and cardiovascular disease together, chronic pain has received less than 0.25% of all research funding. I think now that's changed. I think at the recent conference of the Canadian Pain Society, I think a year ago, I think the value might have risen to about 2%, or between 2 to 3% of all health research funding. So we know that there is so much more that can be done, that needs to be done, and we can really leverage all of the work, the great work that's being done across the country, internationally, as well as the work that's being done also through the Chronic Pain Network, which I mentioned earlier, which is this large CIHR funded strategy for patient-oriented research network that is meant to really accelerate the research lifecycle and make sure that discovery is translated into practice and policy as safely and as quickly as possible, so that the most people benefit. So on that note, I will end now, and I will take questions. Thank you so much.
Thank you. And to our audience, if you have any questions, please enter them into the question and answer box so we can read them out loud. Some questions that came through. Are there any guides or books that you know of to help someone get started with the program specifically related to cancer patients?
Yes. Linda Carlson and her colleague published a book which is Mindfulness-Based Cancer Recovery. Would be an excellent resource. John Kabat-Zinn, Full Catastrophe Living, is also an excellent resource. Those would be the first two that come to mind.
Okay, great. I'll include those links in our follow-up materials to our audience. How do we know the outcome is from mindfulness or medical intervention, as your work is done within a year of completion?
We ask people, so medical interventions. Okay, so the in-depth study with cancer survivors was done with people who were at least 1 year post-cancer treatment. And the medical management was really the first order of business. So each participant in the study met with a nurse and supervised by a pain specialist who came in as needed. And so our nurse was actually a nurse with a lot of cancer pain management experience. And the first thing that's being done is review all the pain management strategies that have been used from a medical and non-medical perspective, and then examine, is there room to optimize that from a medical perspective? If pregabalin or gabapentin has never been tried, is the person interested? If so, let's try that. And then we don't start the group until they have done this trial of medication and now are at a stable medical regimen, and their pain score is not changed. Well, hopefully it's changed. But and I have not taken a look at the difference between time 1 and time 2 in our study, but in the AWARE study, there was actually a lot of people came into the study already and they already had tried a number of pharmacological options. So they were, from a medical management perspective, already optimized, we use the term, and they still had at least moderate levels of pain. And then we take that time point as our baseline to look at the effect of MBSR.
Okay. Is there a website or resource that offers the MBSR material for free?
The MBSR material for free. Well, there are a number of websites that offer mindfulness-based material. Whether they offer the entire MBSR material for free, I would doubt that. But there would be a ton of mindfulness material available online that I know of. In terms of recommendation, I'm hesitant to recommend any specific website, but I would say that the books that I mentioned earlier, Jon Kabat-Zinn's books and Linda Carlson's books, they really go through each of the sessions and each of all of the exercises that would be incorporated into the program itself. And there's also another book, and now of course it's going to escape me, but it's by Tara Brach, I believe, and it's Mindfulness for Chronic Pain. That would be also an excellent resource to look at, and there's a CD accompanying that book of the different practices. Now, reading a book is really not the same as hearing the practice, listening to a guided practice, and practicing. And there's a number of YouTube videos that present different mindfulness practice, some by Jon Kabat-Zinn, some by Tara Brach, I believe. And those, somebody could certainly explore that.
Okay. Is there a multidiscipline program now for patients in Ottawa for a pain program with post-breast cancer?
We have, there's two ways of answering that. One is in terms of a multidisciplinary pain program. We have a program at our pain clinic is interdisciplinary, and anybody can be referred to our pain clinic, regardless of the pain condition that they have. Not everybody gets seen in our pain clinic. Sometimes, depending on what the pain condition is and what management has been tried and what management option exists, sometimes what is being proposed is that a pain specialist works with a family physician, in order to optimize medical treatment. So that would be one way of answering that question. But we routinely have people with breast cancer in our clinic who get seen by an interdisciplinary team. Another way of answering that question is that we still have a compassion study running. So, and the compassion study is this, we're looking at medical management plus an online mindfulness-based risk reduction program, or medical management and just being on a wait list for a couple of months before you get into the MBSR program online. And that would be that's another kind of point of, I don't want to say point of entry, but that's another option for people with breast cancer who are seeking treatments to participate in a structured program.
Okay.
As part of a study.
Another question is, why was pregnancy included in the exclusivity criteria?
This is a very good question. Here we are with women who are breast cancer survivors, and the idea was at the beginning, before we started this study, was, well, we anticipated that a lot of women, a lot of people would want to avail themselves of pharmacological management, and we thought this included another kind of factor to consider in all the medical management that could be offered, and how comfortable would we be with that. Is one way of answering, and then just the changes in the body that can occur during pregnancy. And we would have to then stratify the number. In order to account for that, we would have to make sure that there were the same number of women in the control who are pregnant in the control group versus the intervention group, and then whether or not they would be able to participate in the follow-up study visits was also another question that we were considering in our mind or beforehand. Now, if I was to redo the study again, I would just enroll women who are pregnant or breastfeeding and just say, okay, these are the risks, these are the potential benefits, and just let them discuss with the physician what's the, their best course of action and not exclude them. But I would say that right now, even our motto is that if we have to exclude someone from a study because of there's an exclusion criteria that we can't do anything about at this point, given that the protocol is the way it is, it's been funded, it's been approved by DRB, we still offer them access to group-based intervention that we have as part of the regular programs that we have, and so that they may be able to benefit from it, while letting them know that we don't yet have all the evidence to support whether or not this should be standard practice. They're offered as part of standard practice, and for whom it works and whom it doesn't work, like I mentioned towards the end of my presentation.
Okay. How would a patient become involved in the compassion study?
Contact us. Our email address is painresearch@TOH. Okay. Our email address is painresearch@toh.ca. Or they can contact me, and my email is ppoulin@toh.ca. And I can, if you want to put my email address on the website after, that's fine with me.
Absolutely. We have a number of other questions, but in the instance of time, I can send those to you over email, and we can distribute those to our audience at a later time. For this webinar, sure. Dr. Poulin, is there anything you'd like to add following your presentation?
Nothing to add, but at this point, well, actually, no, there is maybe one thing to add is that an implication for practice, and I do want to underscore that, is that, I mean, I'm encouraged by the results that we see in our studies, but in my own clinical practice, I have had some form of mindfulness practice not be effective, and in some cases actually also eliciting some distress. So like any form of medicine, I think we need to treat mindfulness with care, with caution. And I have, when I do the presentation at the pain clinic here every week for our new patients, I also say, although we have some really good evidence that working on, how you think, how you do things, whether or not you meditate, I know that those can actually have an impact on your pain experience. I say, please never let anybody say to you that, if you're not controlling your pain, it's because you're not meditating hard enough. So I want to kind of leave us with a bit of a word of caution about not seeing mindfulness as a panacea, but maybe as another way that we can potentially support people, and some people, and for some people to support themselves and to explore that with care and caution. And I would end by saying, thank you to everybody who participated today and for your questions. And along with your questions, if you have any feedback for me, I always take it to heart. I'm not used to presenting without an audience and seeing anybody kind of react to what I'm saying. So if you have any feedback for me, I would greatly appreciate it.
And thank you so much for your presentation and your time.